Welcome back to another episode of Superhuman Radio. You see me sucking my teeth. It's because I just finished 3/4 of a pound of bison right before the show. We have a great show planned today, and we're going to be teaching people something most people don't know about. I'm sure there's going to be some people go, oh, yeah, I heard about this before. But by and large, the majority of you are not going to be familiar with this science, but I'm telling you to pay attention to it, because this science that we're going to talk about today may hold in its hands the realities of reversing diseases without toxic, poisonous chemicals as pharmaceuticals. And that's why this is so fascinating today. I'm going to be joined in a moment by Mike Sheikh, and he is really an expert, maybe one of many, maybe one of a couple in the country, to discuss Galectins. You got to, if you don't say it right, you screw up. Here's the thing. The banner, the image has some misinformation on it, but the title has the correct information on it. Galectins are exactly what they sound like. They are human lectins. We've been told by all these doctors telling us don't eat plants because they contain lectins. Well, humans contain lectins. What? How could that be? You know, Dr. Grundy is telling us all to back away from plants because of plant lectins. Well, he may be right about plants, but nonetheless, plants are not the only thing that have lectins. We have them, nematodes have them, lots of simple creatures have them, and we're going to be talking about them because they actually may hold the secret to new therapeutic approaches to diseases. And I don't mean just one disease, multiple diseases. And in one of the discussions we're going to have with Mike, one of these lectins, if it's very high, it's a predictor of death, mortality, not arthritis, not shingles, death. And you want to know about these lectins because you can watch them and monitor them. And we're going to show you today. Mike is going to tell you about ways to actually target them. Michael Sheikh, how are you, sir?
I'm doing great. And now I'm hungry.
Yeah, right. I know, right? Just a little bit. We were getting audio balanced before the show. Okay, where do we start? Now, you've told me there's literally thousands of studies on galectins. How are they being ignored if there's thousands of them?
Well, when you have 4,000 journal articles out there, and if you want, you could do the Galectin challenge. So if you're at home in front of a screen, here's my Galectin challenge. The challenge is type in Galectin 3, so Galectin, Galectin -3, and then type any chronic disease your mind can conjure. Just do that into Google right now. And if you do that, what you're going to come up with are all these journal articles. And then what these journal articles are going to conclude is they're going to conclude, hey, we believe that blocking the Galectin 3 is the ideal therapeutic way to treat this disease indication that you just looked up. That's the brutal reality. So how many times, 4,000 times, do you need to hear something before you actually listen to it? But you're asking, why don't we have anything? Well, because it all boils down to how many people are capable of producing these type of drugs that basically come from nature. They're carbohydrate drugs. They come from nature. How many people can do it? You really need the right carbohydrate chemist to do that. And we actually have the right carbohydrate chemists that can do that. And this is maybe a little known fact, but the word galectin, do you know where that came from? You tell me, do you know?
It sounds like a biblical word for like Galilee or something. To me, I don't know.
It actually came from our CEO, David Platt. I would call him the actual grandfather of the Galectin science. He's not a grandfather yet, but anyhow, he in 1993, the first journal article came out, and he just kind of came up with it. He came up with that name, and it just stuck 4,000 journal articles later. So he's probably one of the most, I don't know, how do I say this?
Well-versed?
Yeah, he's probably the most well-versed person coming up with the name. in the science of galectin. But I really, when it comes to his capability, what makes him so amazing to deal with is everything resorts to theory with him. And he's got a little bit of philosophy background in him. He's kind of fun to talk to. But what it all boils down to is theory. He's of the idea that if the theory doesn't work, why should you be pursuing it? So if he can't figure out something theoretically, why is he going to go down that road? And what you'll see is all his great achievements were done through theory. Looking at the science, looking at how things would bind and interact, it was all done theoretically. And that's why his results that he gets in terms of creating these drugs were so absolutely amazing.
So it's actually a lectin, which is a protein. What's the GA part of it? Galectin. It sounds like two abridged words. Do you know?
It is, but lectin is basically preferential or only looks at and recognizes galactomannins.
Ah, like glucomannan. Yeah,
so a specific carbohydrate is what this lectin recognizes. So it doesn't recognize other proteins.
Right.
It only recognizes these.
So it's funny because we live in a space today where carbohydrates is a bad word.
Yeah,
because of type 2 diabetes, and now you're using it as a drug. You're saying these are carbohydrate based drugs, not chemical based or mold based. Explain how that comes about to realize that there are carbohydrates that can cure.
There's carbohydrate based drugs that what they do is they block the interaction with these galectins.
Mm-hmm.
You see, the galectins, going back to my galectin challenge in the beginning, galectins are the ones that are responsible for all these chronic diseases. So what you want to do is you want to basically silence them. You want to reduce their impact. So what you need is a galectin antagonist. The carbohydrate is the galectin antagonist.
So it's kind of like a suicide, and it kills itself along with the galectin. It attaches to it. It neutralizes it. Or
it basically, it neutralizes it. It has these carbohydrates, this big lanky molecule that folds on itself, does all sorts of things, but also has these little side chains, and those side chains are responsible for attaching to. It's called the CRD. CRD stands for carbohydrate recognition domain. And you know what it looks like? Pac-Man. It looks like a gosh darn Pac-Man.
Right.
So it's like one of these little Pac-Man things. And then what happens is the carbohydrate, the side chain goes in there, and there's the interaction.
Right. Interesting. Now, are we sure that the relationship between disease and galectins isn't corollary? Like, is there research that shows, okay, we see galectins and we see this outcome. When we remove or neutralize the galectins, the outcome goes away?
We've actually seen that. Let's use the most extreme thing that I've ever seen. And that is, we got to go to SARS-CoV, SARS-CoV-2, COVID-19.
Right.
So we come along, I think it was in March, with the theory that, wow, we need to develop a galectin antagonist for SARS-CoV-2 because, man, this could neutralize the virus. And then later on, we got some research out there, and what it did was it checked serum levels. It checked serum levels of Galectin-3 and Galectin-9. There's a paper on this. And you can type in Galectin-3, Galectin-9 into Google, and I can find you the paper. But what happened, or honestly, we have all this stuff on our website. You can go to Bioxtyran Inc. and go to the scientific presentation. It's all there. And you guys can see along with what I'm talking about. But Galectin-9 was actually a predictor of death in SARS-CoV-2. So if you got to this Galectin-9 serum level, the prognosis for you was not good. And if you got to a certain level of Galectin-3 in your bloodstream, the prognosis for you was not that good. And now you're wondering, why is that? I kind of knew that years ago, but that's related to there's this correlation. Let's stick to the correlation before I go off on a tangent. So to answer your question, it was 98% area under the curve for Galectin-9 in predicting mortality in SARS-CoV-2. So you're sitting there going, okay, this stuff kills people. I wonder if we block it. Well, I'll tell you what the answer to that was. The answer to that was just look at our molecule. Look at our molecule, prolactin M, and look at the clinical trial results. And it's for Galectin-3, but Galectin-3 and Galectin-9 were correlated. You see, so when you look at these area on the curves, I think the correlation to death for Galectin-3, the high serum levels, was around 85 to 90%, somewhere in that range. I don't want to be quoted, but it was very high. So when you look at those correlations, wow. But it doesn't stop there. Did you know that there is currently a test right now that you could take for high Galectin-3 serum, and it predicts heart failure? It's FDA approved for heart failure. But the issue on that test is perhaps the sensitivity of the test. There's no one that really knows how to read it. So it predicts failure, but what does it do? I mean, what good does that do me right now? You see, you need more data. In other words, am I at risk of heart failure? You don't want to know if you're in imminent heart failure. It's already happening, right?
Too late. Yeah.
So what good is that? It's the same way with Galectin-9. Oh, I have high Galectin-9s. Well, the reason you have high Galectin-9s is because the disease of SARS-CoV-2 has taken you over the edge. That's why. So we have a correlation there with death, and high Galectins are definitely not a good thing when it comes to SARS-CoV-2. The answer is, what do you do about it? Then there's heart failure. I was pointing to an FDA-approved test for heart failure, but there's some shortcomings with it that I was trying to point out. It tells you you're going to have heart failure. That's definitely not a good thing. You need to pay attention to that and seek medical treatment and all that sort of stuff. But we need to what it also tell us is to tell us that, geez, when these things become symptomatic, we really need to take care of it. Yeah. Now there's another one that I had read literature on. It's Galectin-3 serum levels in your spine when you have this debilitating disease called ALS. Wow. I saw that and I'm going like, well, that could be really interesting.
Huge. Yeah.
It'd be huge. The thing is, though, we need a Galectin antagonist. We need to develop a Galectin antagonist to test some of these theories that we have. I mean, the literature is all there. We didn't do the Galectin challenge, but you could take this Galectin challenge. You can go start talking about diabetes, and then my favorite is cancer. You want to talk about cancer?
Sure, it's one killer.
We can talk about Galectins too, but instead of Galectin serum, we're gonna change the narrative. We're gonna talk about Galectin staining, all right, of your tumors, of your tumor type. So back in 2000, I think it was 2019. Yes. No, it wasn't. No, 2019. Yeah, 2019. So what happened in, I think it was April, there was a journal article that came out, and it did a retroactive study of people that took Keytruda in non-small cell lung cancer.
Mhm.
And what happened is mind-boggling when it comes to correlations. Okay, so we're going to talk about this correlation, this correlative effect. But when people had high galectin expression, and these are people that got approved to take Keytruda, so they did the PD-L1 test or PD-1 test, and they did everything they were supposed to do. Then they took this drug, Keytruda. And what they did was a retroactive study to see, okay, well, what happened if we separated people out by the staining, galectin staining of their tumor types, and we did high, medium, and low galectin staining. When we looked at the results, the retroactive study, if you had high galectin expression, there was a 100% chance that Keytruda was not going to work.
Really?
100% chance. So you're looking at these drug companies and you're saying, okay, this is an interesting journal article. I wonder when they're going to do more research. Guess what? There is no more research on that one. But
so theoretically, if in fact they took a drug that blocked this galectin along with Keytruda, they would have had a much better outcome than just Keytruda alone, right?
yeah, and guess what?
But like, so in other words, they don't care if the patient dies. All they care is efficacy of their particular product and the fallout from it.
Yeah. And you know, I was a big advocate of Galectin Therapeutics. That's that they're a competitor of ours, but they actually came up with the answer. You know what the answer was?
Just do the galectin.
They gave people that were highly experienced, which means they failed like six therapies. Okay. So these people, and hopefully everyone realizes, so let's say you failed Keytruda 6 times. Okay, well, let's give it to you a 7th time and see what happens. But this 7th time we're going to give it to you, we're going to mix it in with belapectin. And belapectin is the name of their drug. And let's just see what happens. Okay, so let me tell you what happened. In a cohort of 3, there was a 100% objective response. Now, what does objective response for the people in the audience? It means you got 30% tumor shrinkage. But what was the time frame? It was only 90 days. But guess what? Out of the 3 people in that cohort, 1 person got a complete response. Means the disease was completely gone. He had melanoma and metastatic melanoma. It looked, if you looked at the PET scan, it looked like he had chicken pox all over his body. Mm-hmm. That was the before, and the after, completely clear. And he took it for 90 days and had that result. Well, does cancer go away in 90 days? No, you got to keep at it. Your immune system has to continue at it. So yes, it had a good effect. But the problem is they didn't keep it on it long enough. So, there's just one example in cancer. Amazing results. What happens? And what it did is it took the study and it validated. So, are you grasping the magnitude of what I'm telling you here? Of what you can do?
These people were, as you said, your term you used, they weren't naive to these types of treatments. All the other treatments failed. So they're lost cause.
All the other treatments with the same drug failed until they added this one.
Okay.
You see? So it's a little bit.
So do you even need that drug if you focus on the galectin?
The answer is yes. I believe that you do. I don't think these galectin antagonists are going to work by themselves. They're really good with combination therapy. Now, the amazing thing is given these anecdotal, or not, these aren't anecdotal results. These are given these clinical trial results. I can't even say they're anecdotal. Given these results, why hasn't anyone done anything with it? Okay. So
money
that's
now?
why I'm here. I am a
Money?
Galectin. I
Is
am
there
a
no
Galectin evangelist. I am
right?
preaching about Galectins and how important they are. And here I am talking about a competitor of mine. And why am I not concerned about the competitor of mine? Well, I think you can read between the lines.
Mm-hmm. So, is there something that predicts higher levels of galectins in people who have certain lifestyles, or lower levels of
Yeah,
galectins?
yes, what you can do is you can, and this isn't FDA approved by any measure. So let me get this out there. But high galectin serum levels are not something that you would want to see. And that is, we believe, and so we haven't done any studies on this, all right, but we believe that if we start doing studies and we start doing these retroactive studies, we're going to see high galectin serum levels in people with cancer, in people with diabetes, in people with heart disease. We already know that one, right? But do you see what I'm saying? But we need a better way to figure out if it's just noise, or do you use it in conjunction with something else? You see,
Mm-hmm.
is it good as a standalone biomarker? The truth is, in COVID, it kind of is.
Right.
In cancer, it probably is. But
Well,
we don't know it yet.
with heart disease, right? When you see the lowering of the target galectin, do you see recovery from heart failure, or are they always broken, just never die?
That's the thing, is we don't know yet because we
Yeah.
haven't tried that. And that's what makes this science so exciting. You're hitting the nail right on the head. There's so much that we don't know. And after 4,000 journal articles, you got to sit there and you got to say, so when are we going to start looking at this stuff?
Mm-hmm.
Well, guess what company wants to do that? I don't know if you're reading, but we're raising our hand. We want to do that.
Right.
Well,
I'm gonna put your website up. I'm gonna put your website up while we're talking.
But what's the challenge? It's money. We need people who want to see a sea change in the way that we're treating diseases out there. We believe we can make a huge impact on meaning Galectin antagonists collectively as a group. We believe there's no one in this business that doesn't believe that blocking galectins, at least galectin 3, for example, isn't a good thing. But now what we've seen is we're seeing that multiple galectins are indicated in different diseases. And we saw that in viruses as well. Viruses, galectins, certain galectins, there's 15 galectins out there. And these galectins, we never really talked about what they were. So maybe we should just give a little bit of overview.
Yeah.
We said, hey, they're proteins that recognize carbohydrates. I mean, we're just kind of dumbing it down. But really what they are is their galectins are made inside the cell. They're intracellular, but then they're also extracellular. Now, intracellular, that universe, I'm not going to open up Pandora's box. I'm not going to get into it. But there's interactions where you could see they're very important. But then there's extracellular. That's where we work. Our molecules work in the extracellular domain. And
do intracellular come from extracellular? Do they migrate across the membrane?
Yes, that's exactly right. So it's made
theoretically, if you alter the extracellular, then you're going to eventually alter the intracellular as well.
Not our drugs. There are some drugs out there that could do that. We have another competitor out there. They're called Galecto. They're a small molecule. Their molecules could. I don't know if they do, or I don't know too much about their technology, but I know it's a small molecule. It could make its way inside of the cell.
Is it possible when it's in this?
What? Oh, you froze up on me.
Sell it.
Can you repeat that? You froze up on me for a second. No, I lost your microphone.
Is the intracellular maybe not as vital as the extracellular when we're talking about, because if you're measuring it in serum, that's extracellular.
Yes.
And if
Yes.
attaching that has an end result, maybe the intracellular really isn't as harmful as the extracellular.
I think the extracellular functions of galectin, I think, are at a much higher level of importance to diseases than the intracellular. So yes, we want it. We, in other words, we, meaning my company, is focused on the extracellular domain. So extracellular, the serum levels, not the intracellular.
Is
So
anyone treating, for instance, cancer with galectin antagonists, or is it agonists? I'm sorry.
yes, I think our competitor Galectin Therapeutics might be doing that. I think that they are on the road to doing that.
Are they considered alternative or standard of care? If usually standard of care is set the body on fire with chemotherapy and zap it with radiation and hope for the best. And if you
that
don't
is
do that,
not a good strategy.
Oh,
That
no.
is not a good strategy at all. And
No.
and I wouldn't recommend it. But remember, I'm not a doctor. Okay, so let me put out that caveat.
Right.
So in other words, I wouldn't recommend that to any of my family. I'll say that. I'll say it that way. But when it comes to cancer and chemo, what happens is we have these great immunotherapy products out there. And then what did I just tell you back in, like I said, in 2019, when they came out with that journal article that showed the correlation? Let me tell you the other side of the correlation. So it was 100% predictive that it won't work. It was 90% predictive that it would.
Interesting.
Or you know what? Maybe I had that the opposite way. But look,
So really, at the end of the day, it was 1% that it wouldn't work. In other words, right? Theoretically.
In other words, if you had Keytruda and you had low or moderate galectin 3, your Keytruda treatment was going to work.
Mm-hmm.
Okay, so why didn't it work on all those other 100% of that patient cohort? Well, let me tell you why. It's because they had high galectin. They had high galectin serum levels or high galectin staining levels on their tumor. So what happened if you would block it? What happened? Well, that's where I was giving you the results in that cohort of 3 that was done in phase 1. We already know the answer to that. Amazing data. And I forget what the name of the new drug is that they did for rectal cancer, where they talked about how great it was. I'm looking at this going like, why is no one talking about this retroactive study? Why is no one talking about these galectin antagonists and what they're doing?
Right.
Why is no one talking about what we've done in COVID? Maybe we should talk about that now.
So what causes the differentiation between galectin 1 and galectin 15? Why aren't they all just the same? Are they like what do they call that? Stereo isomers of each other, or what's the difference between all the different
I'm not familiar with that term, but it all boils down to what does their structure look like.
Mm-hmm.
So I'm going to use my hands here to try to illustrate this. So this is this is a carbohydrate recognition domain. It's a Pac-Man. My hand is a Pac-Man. My other hand is a Pac-Man. And a galectin 1, boom, 2 Pac-Man with their backs to each other, right?
Mm-hmm.
A galectin 3 is let's make a snowflake, like a star with all these things, right. And then we surround the galectins around it, so it looks like a snowflake shape. And then you might have a galectin 9, which has like a bar between it, and then, let me see, a bar between it, and then 2 galectins. So instead of being back, there's a space between it. Right. So what all these things do? What do galectins do? They're adhesion molecules, and what they're really good at doing is stitching cells together, helping stitch cells together. When does that come into play? Fibrosis.
Mm-hmm.
And fibrosis is the scarring of tissue in the hopes of mending it, right? So
Right.
you have cells that undergo apoptosis, which means they basically die and they blow up. And then you gotta stitch that field. So what happens is these fibrosis is created. There's a pathway that creates the fibrosis, and all these galectins come in to basically generate these fibrosis bands and rebuild the network. So they're adhesion molecules that help keep things together, and that's probably why you want to eliminate them so they can't build that fibrosis. Did you know there's animal models out there right now, and what they do is they knock out the gene that produces galectin-3. They're called galectin-3 knockout mice. Guess what happens if you want to insult their liver, for example? You can bombard them with toxins. It goes straight to the liver, right? You're going to create some fibrosis. Guess what?
No.
Nothing. You take away that galectin-3, you're taking away the building blocks for fibrosis. It's
What-
so
I
it's
wanna-
proven in animal models.
I'm sorry. I didn't mean. I want to ask you a question before we go into this break. So, what does does type 2 diabetes correlate with high galectin levels? And if so, what does diet have to do with modulating, moderating, or increasing galectin production?
Okay, there is a correlation between galectin-3 serum and diabetes. Absolutely. Just type it in to Google right now and you'll see the journal article. So for me to answer that question, I really got to go look at the journal article. I don't know the answer for it, but what I do know is that they are in fact correlated. And I would like to look at diabetes a different way. And when you look at it this way, what is diabetes? It's really fibrosis of the pancreas. I want you to think about it that way.
Is it really? I mean, we could think of it that way, but not all diabetes comes from a fibrotic pancreas. Not all of it does.
Well,
right?
no, not type 1, no. But I'm just trying to create a higher level understanding of it.
So we know, like for instance, we know that the ketogenic diet, the real ketogenic diet, when you're eating a lot of fat, moderate protein, and virtually no carbohydrates, it can reverse metastatic cancer, it can shrink tumors, it can do a lot of magic things that we're talking about here. Now, is it realistic for people to go on that level of a ketogenic diet? Most people won't. They can't. With that being said, what happens when you eliminate carbohydrates from the diet? Now, all of a sudden, these things got nothing to hang on to, right? Is there a suppression?
No, they're a function of, remember, they're excreted from cells. Okay, that's where they come from. And they fine tune your immune system. That's another function that they have. So one of the functions so that's why I'm saying galectins are so multifaceted. So here they are. They have the ability to really control this fibrosis. But what else do? They modulate the immune system. All right, that's another function that they do. If you think about it, and I'll give you like one example. You have neutrophils in your lungs. So how do they swim upstream? They need something. They need some sort of adhesion molecule. And there's a couple of journal articles that have showed that galectin-1, for example, is that adhesion molecule that these neutrophils use to kind of stay glue, like pretend you're in a bat cave or something, and you're hanging up there, and then all of a sudden you get this cytokine that says, hey, come over, and then they release, and then they go and they flood. It's kind of like that. I don't know if I gave good imagery, but that's kind of what these adhesion molecules can help do. Do you see how that is like modulating the immune system? You kind of see how it's tied in? That's I'm just trying to give you one of the ways that it modulates.
Yeah. I want to take a successful commercial break this time.
Yes.
And when we come back, I've got other questions. I want to talk about the thymus gland, because we can't talk about fibrosis without discussing the thymus, because the thymus has an entourage of peptides it makes that are actin sequestering. And not only they can prevent the buildup of fibrotic tissue, but they can actually reverse fibrotic tissue. Lots of good studies. I did a deep dive about a month and a half ago on thymosin beta 4 specifically. So thymosin beta 4 is one of the hormones made in the thymus gland. The thymus gland, pretty much after around the age 40, starts to atrophy and shrink. It's the major contributor to our immune system, and it has profound effects on not only sequestering actin and keeping it from becoming fibrotic tissue, but literally reversing fibrotic tissue. Studies on rodents and humans show that it can reverse fibrosis of the liver, and as well as the lungs, the kidneys, muscle. As you said before, fibrosis is a nasty thing. In fact, I think that fibrosis is a major part of what we consider the phenotypical aging. You start moving slower, standing up hurts, everything stiffens, you get, you just feel like you can't move like you used to. And fibrosis also hurts the myelin of the sheath of the nerves as well. And the research on thymosin beta 4 specifically, that 43 amino acid domain, it has profound effects on reversing fibrosis. Do you think that there's a role or a correlation between what thymosin beta 4 does, or let's say thymus gland hormones in general do, and the galectins accumulation?
Oh, Carl, remember my Galectin challenge? What do you think I did during the break?
You looked at thymosin beta 4.
No, I looked at thymus and Galectin 3.
It's called thymosin Galectin 3?
Yeah, that's all you had to do. You can go and you'll see the journal article. So I'll distill what I learned over the break.
Okay.
To answer your question. So what they found out is, remember, there's this type of mouse, it's a knockout Galectin 3 mouse.
Mm-hmm.
Okay. So let's just take away the Galectin 3 gene. What happens to the thymus? It atrophies in mice. Does that explain it? So what's the thymus designed to do, right? It's designed to regulate your immune response. Am I correct?
Mm-hmm.
So what happens is what you talked about, is the atrophying of it as you get older. So, and
I got it. So what you're saying is that the high Galectin 3 actually is contributing to the atrophy of the thymus. Is that what you're saying? Ah, interesting. Very interesting.
See how it goes in that feedback loop?
Yeah, very interesting.
So now keep in mind, I just learned that over the break. So, but the thing is, if you were to walk away from this show, I want you to realize how big this is. This is the therapeutic target of this century. Remember last century, it was really all about infections. This antibiotic, that antibiotic, it all started with penicillin. Now, this century, I think it's about viruses, whether it's HIV, whether it's Ebola, whether it's the Zika, whether it's the dengue virus, whether, I don't care what virus it is. Viruses are a big thing. And up now, SARS-CoV-2, right? So we have an antagonist that can treat something, or we believe these type of antagonists can treat all sorts of viruses. That is how big this is. So I don't think, see, what happened is there's research out there that tells us what galectins are elevated in certain different viral diseases. So once we figure out and we can make that antagonist, and our company, by the way, has the technology, we believe, to customize carbohydrate antagonists for galectins, and multiple, mind you. We're really excited about being able to tackle I think we could tackle hundreds of viruses, to be honest with you.
So we have a question from a Facebook user whose security settings do not allow me to see their name, and maybe they'll post their name next.
Mhm.
Galectins are implicated in Lyme disease too. Is that true? Borrelia? There's I guess a bacteria that's a virus that's associated with Lyme disease. Do you know if that is true?
Let me tell you, this is the Galectin challenge, right? I almost guarantee you that it is, right? But
that question comes from Brian Cunningham. So he's a long
yeah.
time.
So there's Dr. Isaac Elias. He pops up right away, and he's a big proponent of using modified citrus pectin, and modified citrus pectin is supposed to be a Galectin-3 antagonist. There's some tests. I don't know if they do the tests on every single batch, so I use that supposed to be. I'm not like downplaying it or anything like that, but
and it has to be modified. Modified citrus pectin is a fermented version of citrus pectin. You can buy 10-pound bags of citrus pectin for like $6 on the web. It doesn't work. It's not in the smallest possible size for the body to utilize this way. I just wanted to mention that before people start buying tons of citrus pectin.
But let's look at this from a higher level. Let's look at, so take again, it all starts with the theory, right? At least, so let's take this at a higher level when we're looking at Lyme disease. Lyme disease is, I think, believe that that bacterium just never leaves. It just stays latent in the system and constantly pokes and irritates. And it's that same sort of persistence that I think we're seeing with long COVID, which is why there's such an overlap between what we see in Lyme disease and long COVID. Do you see? And there's research out there where they're looking at ME/CFS, they're looking at Lyme disease, and they're looking at long COVID, because all the symptoms are they're almost identical. They're hard to tell until you actually do the blood work and look at it on a granular level. And I think the people that have done that work is Dr. Bruce Patterson. He's very big into looking at the differences between Lyme disease, ME/CFS, and long COVID, for example.
Interesting. So, citrus pectin is a type of soluble fiber. Am I correct on that, or am I wrong?
Hey, if you ever tried to mix that stuff, it doesn't seem very soluble.
So maybe it's insoluble. Okay, so maybe, but it is a form of digestion-resistant carbohydrate, is it not? It's a fiber, right?
I don't know enough to answer that, so I'm going to pass.
Okay. With that being said, carbohydrate drugs are coming from food sources, correct? Couldn't you? What I'm getting at is, couldn't you just make a single product that addresses all of the galectins, and people could take it as a prophylaxis?
Probably not, and I'll explain why. We still haven't figured out how to get it from here through the gut. We believe that there's some bioavailability with our latest compound, but we really don't know the answer. So the truth is, we don't have the money to figure out these gee whiz type questions.
Right.
And if we did have the money, we'd probably spend it more on getting therapies versus the gee whiz nice to know stuff. So the main way that you'll get a galectin antagonist is through intravenous, because then you don't have to worry about the bioavailability. It goes straight to what it's supposed to do. We know the galectin serum levels are high, and blocking it's probably going to have a positive effect.
Are these big molecular weight? These proteins, the galectin antagonists, are they large molecular weight?
That is our special secret sauce. So I'm going to say yes, they are, but I'm not going to get into what they are.
The only reason I ask that is because intravenous people have become comfortable with injecting growth hormone, insulin, and everything else.
Mhm.
There's a lot of emerging delivery systems, that are making transdermal vehicles deliver much larger molecules than we ever thought possible.
Well, Carl, our prolactin M, it's thought to be absorbed through the mucosal membrane.
In the buccal. Wow.
Yeah, the buccal. Sorry, I mispronounced it. But the buccal membrane in your nasal pharyngeal area. I mean, that's what we believe. That we believe it gets through there, which is why we had such great results. Should we tell people what we did or no?
Yeah, no, go for it. Well,
Yeah,
and
so
let's answer Katrina's question first, and then I'll let you have the reign.
sure.
How does someone get tested for various galectins? Will your doctor test for that, or are they too far behind?
No, I think you can get a test. I know some people that have said, "Hey, Mike, I got cancer," and I'd say the first thing that you want to do is, hey, get facts, find out if you have high Galectin-3 serum, and they've done that, and they have gotten a test. I think LabCorp does a test because we know it's FDA. The Galectin-3 test is FDA approved for heart failure, so we know it exists. There's a test kit for it. Yeah,
and then at least you can know whether or not Keytruda or whatever they're going to give you is actually going to work.
Remember, I'm not giving medical advice to do.
No, I am. I'm not a doctor. They can't take it away from me. I'm just a misinformer. That's all.
But yeah, I think I really don't think that would be a stupid idea. Is to get the facts and find out if you have high Galectin-3 serum in your, or it's actually staining of the tumor, so they can stain the tumors for Galectin-3 like they did in that study, and you can see. But there's a lot of anecdotal evidence on cancer. But
tell them the story that you wanted to tell them, what you guys have done at your company when I asked you about the multi-fat, transdermal and all that sort of stuff.
Yeah, what I was getting into is our clinical trial results. So we did we had a clinical trial. It was very impactful. We eliminated, and I want to repeat this, we eliminated SARS-CoV-2 in 7 days, 100% elimination. But that means nothing unless I give you the control. The control was 6%. And the truth is about that control number, man, it was right on, it was rounding error, to be perfectly candid. So that's in 7 days, but that's not the real story. The real story is when we look at our 3-day data. 88% of the people were SARS-CoV negative in 3 days. So what that means, SARS-CoV negative, PCR negative, that means doing the nasal PCR test. That is the definitive, hey, are you infectious or not, right? That's what everyone, that's a metric that we use. So we get 83% of the people are SARS-CoV negative in 3 days. Now let's take a look at Paxlovid, for example. Paxlovid, in real world studies, they get 30% of the people PCR negative by day 20. Do you want to be sick, spreading this disease to your loved ones for 3 days, or 20 plus days? I say 20 plus because that was 30% versus 88%. It's really not a fair comparison.
Right.
And then do you have those people that take Paxlovid, the numbers are still coming in. 1 in 5 get long COVID, for example. So now, what do you think? We don't know the answer to this, but you can just guess. What happens to people that get over it in 3 days, for example? Do you think that they're going to be at higher or lower risk for long COVID?
There's no long COVID.
That's what I'm saying. And that's what I'm saying. The disease hasn't had a chance to really lock into your body and get into those reservoirs that never end, that never cease to end, spitting out the virus. Mm-hmm. So that's why we're very hopeful, and we can't wait to get to that phase 3. But all this that I'm doing, all this gee whiz stuff takes money, and that's probably our biggest challenge right now. Is that we don't want we're hoping to get some money in the doors so that this science doesn't get left in the dust, because this science, it's going to come out there. We're going to have a breakthrough. It's going to happen. And truth is, I think our SARS-CoV-2 medicine, that it's not approved by any stretch of the imagination, so I shouldn't call it that. Our SARS-CoV-2 experimental drug, when that comes to light, we think there's going to be a lot of things out there. Like one of the things that I'll break here for you is we've done some in vitro type studies on RSV. Is that a small little problem that we heard of this year?
They wanted you to be afraid of it. That's for sure. They wanted you to be scared of it.
So there's RSV, and then there's influenza. I mean, how long have we had influenza out there? For a while, huh? Okay, so we did in vitro tests to see if there's any activity. What do you think the answer is?
Yes.
Thank you. Thank you.
So are you targeting, for all these things, are you targeting exclusively G3 or with, I mean, like with COVID, you targeted G3 with that one as well?
We only did a test on G3. Is that the right target? You got to go look.
Got it. But still, those are remarkable results. Maybe there is a better target. Who knows? But
yeah. The thing is what, again, we only tested for Galectin 3. Could this be theoretically another type of, a multi-Galectin antagonist? It probably is. I haven't tested yet, so I'm not gonna, go on the fringe and say that. But it probably is a multi-Galectin antagonist. And our other molecule, Prolactin I, we also have an intravenous one. It's probably a multiple Galectin antagonist. We haven't tested it at all.
Right.
So I can't say that yet. Okay. But we did in NMR technology, with NMR resonance technology, nuclear magnetic resonance imaging, we verified that our molecule, Prolactin M and Prolactin M, it bound to the spike protein. Or not bound to spike protein, it bound to the Galectin 3. So we know that it's a Galectin antagonist.
Right.
Not 99%, 100%.
You're not going to hear this stuff from your doctor. He's not going to come out and say, hey, let's look at Galectin 3. He's not. He's going to say, let's get you signed up for chemotherapy. And you've heard me say this before. Chemotherapy is like burning down the entire house to get a stain off the carpet. It's horrible. Most people, they have a 5-year, they say 75% of chemotherapies is successful. Well, yeah, 75% of them either lived 5 years or more or died from something else, like cisplatin destroys your kidneys. Radiation to the left breast in women who have breast cancer, they end up with heart problems. So don't be fooled by, oh yeah, we have a great success rate with chemo. Yeah, you don't die from cancer, but you die from other things. So I just want to go on the record for saying that. I'm sorry, I didn't mean to take a pity party for myself. Anyway, let's finish up. We have a question here. Let's see who it is. So I can't read that. Me and you, Thalat, on Facebook says, what effects do Galectin antagonists have on antibodies?
Okay, good question. Galectins, Galectins don't have, I don't believe, any effect on antibodies, because remember, we're talking about the Galectins themselves. They specifically recognize the carbohydrates. They don't recognize antibodies. They don't do anything to the antibodies. Perhaps maybe the question is regarding how our molecule would interfere with perhaps an antibody that's designed for SARS-CoV-2 is what I'm thinking, right? That's where I think the genesis of the question is. I'm taking a leap. So when, you know what, I got my little, I got my little visual aid. So this is SARS-CoV-2, or a
Right.
cartoon version of it. So the antibody comes and attaches onto the tip, right? So what our molecule does is it's called the galectin fold. We believe our molecule goes right into the galectin fold, which is on the side of the spike protein. So no, we don't think it interferes with the action of an actual antibody, but that antibody is going to need the immune system to recognize it. And the way our molecule works is there's, let me get this like sound bite out there so that I can really just dumb down our approach.
Okay.
There were 10,000 plus clinical trials worldwide on SARS-CoV-2. 9,900, and I'm saying this figuratively, 9,999 of them are all going after the same approach. They're trying to take the immune system. They're trying to squeeze more productivity out of it, make it work smarter, faster, harder to clear the virus. Their whole goal of all the approaches are to clear the virus faster. What do? We come in through the mucosal membrane, of course, buccal membrane, rather. We come in through there. We bind to the virus. Where do we bind? We bind on the side. We neutralize it. We prevent entry. That's the difference, and that's the idea. And we do it how fast? Extremely fast. We're not waiting for some colonal expansion of the B cells and the T cells. We're not waiting for any of that. We do it right away. And as long as you keep doing it right away, what happens is this fire dies down in you, which is the virus. And then your body's own immune system attacks it. I just gave you basically a little bit of idea of the mechanism of action of how our drug works with that. So I hope you don't mind that little pivot.
No, that was good.
Answer the question.
That was very good. Do we have anything we've missed? I'm looking on I think we've covered everything.
What about the long COVID?
We've done shows on long COVID, and there's a lot of different theories, but obviously if it works that fast, there is no long COVID. Even if you have long COVID and you take it once you've been diagnosed with long COVID, I would imagine this approach would probably clean it up pretty quickly. Have you given G3 or other Galectin?
What we are doing is we're going after the long COVID indication, because long COVID does create lots of fibrosis. So the top theories in long COVID, and I'll just cover this very quickly. It's number one is you have the viral persistence, or you have these viral fragments that are out there. The second thing is tissue damage. The tissue damage is from the clots, the blockage, basically the breakdown of the endothelial cells. What I don't want you to do is I don't want you to look at ritonavir, which is part of Paxlovid. I don't want you to look at what that does to endothelial cells. You'll be horrified.
Which one? You're talking about remdesivir or something else?
No. I'm talking about Paxlovid. So Paxlovid is nirmatrelvir plus ritonavir. Ritonavir, if you look at the side effects, it impacts these endothelial cells. So when you look at it, when you look at the NIH doing the biggest long COVID study on and using this medicine, you're just kind of doing one of these things.
Well, it's funny that all those drugs are coined the name, oh no, death is near, like the remdesivir.
Oh, remdesivir. Yes,
I mean, they're all like, oh yeah, they seem not to be complementary to health. Let's put it that way. And that's probably part of the problem. The pharmaceutical industry has gotten away too long for creating drugs that do a specific job, but cause catastrophe and fallout around it. It's like, okay, you made the virus go away, yay, but all the people got heart attacks. Oh, but you made the virus go away. Yes. And that's kind of like, we've allowed the pharmaceutical industry way too long to have acceptable unwanted effects. Not because if a drug works, it does it. That's a side effect that it works. But we've accepted for too long thanks to our politicians who are in big pharma's pocket. Oh yeah, well we cure the heart attack, but yeah, they're going to get cancer. But that's a necessary. Like it's like the pharmaceutical industry looks at things like the lesser of two evils. Yeah, you're going to die, but you're not going to die from the disease we're treating you from. And
isn't that kind of what happened with the vaccine? That they're I mean the same sort of.
I don't want to be.
I'm sorry.
No. I'm going to say no. I don't want to be a conspiracy theorist because that's what people are going to say. But the fact that, first of all, the fact that this was pushed on the American people the way it was tells me there was more to it than saving lives. And as a result of that, we are actually seeing fallout from the vaccine. You can't deny that. This is accurate. Other countries are releasing their data. Israel just released it Israel is the most vaccinated country in the world. Sure. They're like 99% vax and boosted. And now they're seeing the I just watched a show the other day of the Knesset. They're like ready to fight because they're saying all of our people that we've hurt with this. It was a money-making scheme. That's what it really was. I mean, look, these pharmaceutical companies have been called on the carpet tens of dozens of times and had to pay billions of dollars to the UK and other countries for scamming in the name of modern medicine. It's really sad. And so you have to make your own decisions today. The government isn't going to tell you the truth about anything. They're not telling the truth about this train that just caught on fire and just north of me. They said, oh, it's a controlled burn. So now all of a sudden, people within a 10-mile radius, their chickens, their deer, everything's dying. Oh, it was controlled. It's safe. It's okay. So when the government says something, are they being malicious? Are they being creepy and crooked? I don't know. Maybe they're just so incompetent. But regardless of what it is, neither one of those are qualities that somebody should have that's running a country. And so you got to really be an advocate for yourself. If you don't think you should do something, then don't. You know what's best for you. Don't turn everything over to somebody else. That's all I'm going to say about that. That's it. Hey, this is a fascinating discussion. I'm really excited to learn more about Galectins. I want to put the website up again. If you are someone who's a certified investor, you invest, and you'd like to learn more about this, because investing in these kind of things has profound sociological benefits. When sure, you can invest in Apple, the next iPhone comes out, now your stock just went up, but these kind of investments actually save people's lives. And if there is a heaven, which personally I don't believe, I don't want to, everybody knows that I'm not that guy. But if there is, this is definitely a way in if you invest in a company like this and it works. That's all I'm going to say about that. All right, look, Michael, thanks for being here today, and sorry for all the mishaps, really.
No, it was a pleasure being your host, and hopefully we'll be back.
Yeah, definitely. All right, and we'll see everyone tomorrow. We have an interview tomorrow with the folks at Newtopia about a couple of their new products, especially their sleep product they're having great success with. So if you have issues about sleep, maybe you should check it out tomorrow, and we will see you then. Bye-bye.